Hello, wherever you are in the world, and welcome to the Power Over Scoliosis educational webinar. We have an interesting and fun program planned for you tonight with lots of questions and answers. I'd like to introduce, first of all, some of our faculty. Next slide, please. Baron Launer from New York is the co-chair and the co-moderator of this, and I'm Dave Clements from Camden, New Jersey. Next. Next, please, Harvey. Nope, go back. We have three excellent faculty from all around North America. We have Dr. Harry Schuffelbarger, one of the legends of scoliosis care, who's in Florida. Feroz Mianji, who's in Vancouver, British Columbia, one of the new up-and-coming young surgeons and researchers, and Pat Cahill, very well-known, established scoliosis researcher from Philadelphia. We're very pleased to have these three experts with us tonight. Next. And we also have two patients who are willing to discuss their experiences with undergoing scoliosis treatment. And they're one of the most exciting part of this webinar. Next. Here are the instructions to how to participate. Guest microphones are muted. The presenter's audio will be on. You can give questions through our Zoom Q&A section, and we'll read them at the appropriate time. Feel free to submit questions throughout. And the questions will be presented by the moderator to the experts. We hope to get to all the questions, but sometimes we don't have enough time. Next. Here's our agenda. We're going to start out with Dr. Launer going over what is scoliosis, and then we're going to have our two patient experts give us their stories. We're going to talk about genetics and about the scoliosis as a genetic disease. We're going to talk about fusion versus non-fusion treatment, and then long-term outcomes in pregnancy with Dr. Cahill. Next. Setting Scoliosis Straight is a nonprofit, meaning that we rely on donations in order to provide these educational services to you. Our mission is to better discoveries and advanced techniques in the treatment of spinal deformity in children and adolescents worldwide. And our vision is a future where children with spinal deformity have the ability to lead healthy, happy, and productive lives. This webinar is part of that mission. Next. So I'd like to turn the program over to Dr. Launer, who's going to talk to us about what exactly is scoliosis. Dr. Launer.
Thank you, David. And it's great to be with you and our colleagues and Alexis and Sofia this evening, and with all of you patients and families. So what is scoliosis? Next slide, please. Well, first of all, it's important to know what is normal. And the spine is normally straight. If we look at it from the front or the back, we have a straight spine, and we can see that on the x-ray. And in the side view, we call that the sagittal plane. There are a series of curves that are normal and that we all have to varying degrees. Next slide, Harvey. But when we look at scoliosis, it's really more than just a side or a lateral curvature. And you can see two different x-rays that appear to have similar curves, really on the three-dimensional look at this using an EOS, which is a specialized x-ray, biplanar x-ray it's called. We really see that the spine is in 3 dimensions quite different than what just a simple x-ray shows us. Next slide. And we can classify scoliosis by its cause. And the most common type of structural scoliosis, and what we'll focus on here today, is idiopathic or genetic scoliosis, comprising 80% of the total list of curves. And there are non-structural causes like a leg length discrepancy, or a patient who has back pain or sciatica may lean one way or another, and it appears that they have scoliosis. But it's not a true scoliosis, it's a functional scoliosis that disappears generally with treatment. Next slide. And here's the list of many different types of scoliosis, and time will not permit for us to go through them. Next slide. The most common form is idiopathic, as I said. It's an S-shaped curve, is a common presentation on the left. And you can compare that to here, a case of congenital scoliosis, where we see a half of a vertebra, we call it a hemivertebra, in which there's a local or focal scoliosis that's caused by a misshapen bone that occurs before birth. Next slide. And so we're talking about today adolescent scoliosis, which comprises 80% of all types of idiopathic. So patients can present from birth to age 3, infantile, or from 3 to 10, but the most common form is adolescent. Next slide. And if we look at curves in general, 2 to 3% of the pediatric population has scoliosis. And of those that require treatment, either a brace or surgery, curves of greater than 30 degrees, there's about a tenth of those patients. So 1 in 100 of those patients that present with scoliosis will need treatment. And it's much more common for a girl than a boy to need treatment, 10 to 1 girl to boy. Next slide. And so if you go back one, Harvey. Well, why do we treat scoliosis? Because it can impact quality of life. And patients may have body image concerns about the shape of their body as a result of the scoliosis. And in the adult, curves can be progressive, they can get worse, they can cause pain, and they can have an effect on lung function, and in the adolescent patient as well. Next slide. And so it comes in different shapes and sizes, different curve patterns, different severity. Next slide. And some patients whose curves progress beyond 40 degrees during growth or 50 degrees or more in the mature patient, we may need to consider surgery. And non-fusion may be considered for curves really 35 degrees or greater and up to 65 or 70 degrees. Next slide. And the standard approach has been spinal fusion, which can result in excellent outcomes. And here, patients' outcome scores are quite good. Next slide. And here's a non-fusion option. So I'm going to stop it there, and we're going to get to the next talk. And I think David's going to introduce our next speaker. Or I'll introduce. Sofia is going to be our first speaker for her patient story. We look forward to hearing from you, Sofia.
Thank you so much. Next slide, please. Oh. Hi, my name is Sofia Musico, and I'm thrilled to be a spokesperson for Setting Scoliosis Straight today and tell you all a little bit more about myself and my journey with scoliosis. So first, a little bit about me. I'm a 16-year-old from Toronto, Canada, and I was diagnosed with scoliosis when I was 14. My parents and doctors have noticed curves in my spine since I was born, but it wasn't until a formal checkup at age 14 that I was referred to an orthopedic surgeon. Here, my story becomes a little different. I was diagnosed with thoracolumbar scoliosis. I have a double curvature, meaning each curve is measured 33 degrees in opposite directions. While my scoliosis does cause me day-to-day pain, I'm not a candidate for neither bracing nor surgery. As I'm curved in a perfectly symmetrical shape, a brace would have no effect on my scoliosis at this point in my growth. And because my curvatures are a few degrees shy of being considered severe angles, I don't urgently need surgery. This situation puts me in a difficult and unfortunate limbo. I'm physically affected every day by my curvatures, but I can't do anything about it. This dilemma was as motivating to me as it was difficult. In September of 2020, I saw 2 of my friends plan and execute a marathon for Kids Help Phone. My first thought was, wow, I would never be able to last that long walking with my back. But it only took for me a second to realize maybe that's a problem, and that is something that I would really love to advocate for. And that is how my foundation, called Idiopathic, came to be. Through Idiopathic, I raise money for Setting Scoliosis Straight by designing and selling sweaters and collecting pledges for a yearly walk. This year on March 20th, me and my friends walked 33 kilometers across Toronto, which is 1 kilometer for every degree of curvature in my spine, which is about 20 miles. I like to call this walk my path part of Idiopathic. While this long distance seems rather daunting, I had endless amounts of support from my 9 best friends through the entire process, and even only 7 of them could come on the walk. The other 2 supported me all the way from Pennsylvania and Northern Ontario during my walk. I think the part that I'm proudest of my initiative was how I collected donations. Targeting my peers, I knew that crowdsourcing donations would be rather difficult without an incentive, especially when the audience that I sought donations from were teenagers mid-pandemic. My solution was to put my own X-ray on the back of a sweater, which I designed myself, and I sold them to collect all the profits for Setting Scoliosis Straight. Even though I designed and organized the entire initiative myself, I really owe the success of my foundation to my friends and my loved ones who have shown me endless support for my efforts. Another huge part of my life, which is just as motivating and important as my initiative is my education and my academic life. I have a bit of a love-hate relationship with school because even though reading and learning are some of my favorite things to do, it's almost unbearable to sit in those rigid school chairs all day long. I'm so motivated to work hard at school because I want to make a positive change with my education, especially if it means benefiting scoliosis patients or contributing to the development of new technology. Today was actually my last day as a high school junior, and my ACT and final exams are in the coming days, so it's really rewarding to look back on the year and see how far I've come academically and with idiopathic. My journey with scoliosis has been really difficult, yet really inspiring, and I'm very proud of myself for staying so positive through the most painful parts of life. I couldn't be the person I am today without my family and my friends, and I'm very proud to be someone who has worked really hard to improve the lives of others, especially with setting scoliosis straight. I highly encourage everyone to start your own initiatives about a cause that you are passionate for, because there's nothing more rewarding than knowing that your hard work benefits and supports people all over the world. Thank you so much.
Terrific, wonderful story, Sophia. Let's now go on to Alexis and her patient story.
Hi, first slide, please. Well, hi, my name is Alexis Thompson. I'm 13 years old and I live in North Dakota. I'm honored to be the reigning national 2020 Princess of America Junior Ambassador, but my journey to this crown has been anything but easy. In March of 2018, it was noticed that my shoulders were uneven. My parents took me to a free screening clinic from Shriners Children's, where doctors found 3 curves, 1 in my neck and 2 in my spine. Diagnosed with adolescent idiopathic scoliosis, I was fit for a first back brace that I had to wear 20 hours every day. At first, wearing the brace was not fun and honestly a little bit scary. It's restrictive and it was really difficult to get used to. Luckily, I was able to continue dancing because doctors told me that exercise is important and dancing keeps my body strong and flexible. I had no pain with my scoliosis until February of 2020. Next slide, please. My spine had been stable for 2 years, and when we went to my appointment in June of 2020, we realized that my spine curvature had jumped. No wonder my back had started hurting. Another 10-degree jump meant that my curve measured 45 degrees. Next slide, please. At that point, surgery was almost inevitable. I wanted to avoid the spinal fusion if at all possible, and I was asked if I could consider a vertebral body tethering or a VBT surgery. VBT has a very limited window of opportunity for the surgery to take place in. I was almost out of that window. My family had a very difficult and fast decision that we had to make. Just 2 weeks later after we made the decision, on August 13th, 2020, I had my VBT surgery. At just 6 weeks post-op, I was told by my surgeon that I could go back to dance. At 12 weeks post-op, I was officially recovered, and I have had no pain since surgery. Next slide, please. I've learned that I can find the good in any situation, but I'm not perfect. There were days when I didn't want to put on my brace, or I was crabby because my favorite shirt didn't look good with the brace, and there were days when my back hurt because my brace was pushing on it. Recovering from surgery wasn't easy either, but I pushed through all of it. I've learned that you can find happiness in any situation, even when it's difficult. And it's okay to be frustrated sometimes. Just don't dwell on it for too long. Always choose happiness. After VBT surgery, I've been able to continue dancing, and just 14 weeks after major spine surgery, I competed at the National Princess of America pageant and proudly walked away with the title of Princess of America Junior Ambassador 2020. Next slide, please. I'm an advocate for scoliosis patients and continue to expand my organization, Embrace You. I created Embrace You to advocate for scoliosis patients, provide peer-to-peer bags to scoliosis patients for brace transportation. Next slide, please. It can be difficult to find large, sturdy bags for the cumbersome back braces. Embrace You provides stylish bags, which are given to patients when they receive their back brace from their physician. Embrace You currently partners with Shriners Children's, and the goal is to distribute brace bags nationwide. Next slide, please. I also hold an ongoing toy drive, which benefits Shriners Children's. In 2018, when I first started going to Shriners, I was given a toy after tests or procedures that were uncomfortable or even a little bit scary. I realized that there weren't many toys for older kids, so I decided to hold a toy drive specifically for them. My toy drives have helped over 600 patients, and I've raised over $2,500. Next slide, please. Raising awareness about scoliosis is very important to me. I started an annual scoliosis awareness campaign where I work with local media and doctors to provide free scoliosis screenings. And I've held a scoliosis awareness walk around the North Dakota state capitol. Next slide. I love public speaking about Embrace You, my scoliosis journey, and how to choose happiness despite the circumstance that you might be facing. Where I live, scoliosis screenings are no longer done in schools, and so all too often kids go undiagnosed. I recently spoke to the North Dakota Senate informing them of the importance of scoliosis awareness and ensuring scoliosis checks are being done in all schools and in all physician visits. Next slide. I am honored to be a partner with Setting Scoliosis Straight as a patient ambassador. I recently spoke to the Food and Drug Administration, or the FDA, where I shared my scoliosis surgery experience and my outcome with the nation's top doctors and FDA staff to help them learn how scoliosis treatments are affecting the patients and their caregivers. Next slide. When I was first diagnosed, I didn't know any girls like me. I found a support group called Curvy Girls, and then I brought the very first Curvy Girls chapter to North Dakota, and I took on the role as the leader. My group gets together every single month, and I plan fun activities for us to do, like yoga classes specifically for scoliosis patients and bowling. I love connecting with the girls and giving each other advice and encouragement. Last slide, please. I'm embracing my scoliosis journey and sharing it, good and the bad, to hopefully inspire others. I encourage you to embrace challenges because through every difficulty comes strength. Scoliosis is a lifelong journey and it makes you stronger than you will ever know. Going through this journey can be difficult and frustrating. I know because I've been there. But don't forget to find the positives in whatever curveballs life throws your way. Always embrace you and your journey. Thank you.
Well, thank you so much, Alexis and Sophia, for your inspiring stories. And we really appreciate that, that you shared these with us. We're now going to move on to Dr. Schuffelbarger's talk. And Dr. Schuffelbarger is tremendously experienced and has been a leader in the treatment of scoliosis for many years. And Dr. Schuffelbarger is going to talk to us about genetics and scoliosis. Harry.
Thank you, Baron. Good evening, everybody. My task is twofold: the role of genetics and common misconceptions about scoliosis. Next slide. Some of this is repetitive, but scoliosis is probably one of the more common inherited conditions that affect the pediatric population. Worldwide, about 2 to 3% of the population has some curve in their back. And most of these are small, non-progressive, and really never a problem. A small percentage are a problem, as we'll touch on. There's over 10 million adolescent and pediatric patients in the United States with scoliosis. Again, most of these very mild. It certainly tends to be familial. Next slide, please. This is one, back up. Go back again. Okay. I'll go forward. We're going to get a picture. So as we said, it's genetic. It is passed within families. The graph on the right is a kinship coefficient. And this is a result of a long, tedious familial study. And what it shows is that people with scoliosis are more related to each other than the normal population is related to each other. And this is an idea of common genes. The inheritance pattern is incomplete dominance. It's polygenic, meaning the location is on multiple genes, not just one. And it has a variable penetrance. And what this means is some people get it almost nothing, and some people get it bad. A very few get it really bad. So there's no way to know at the start who falls in what category. Next slide. There are environmental influences that affect scoliosis. We're really unable to identify exactly what those are. In mild curves, the male to female ratio is approximately equal. However, in the progressive forms are much more common in females than males. And these are patients requiring treatment. Multiple genes have been identified, and genome-wide association studies exist at several centers in the United States and Europe. A genetic test for scoliosis, not yet. There was a genetic test called ScoliScore 10 or 12 years ago, which we felt was the answer to predicting who was going to progress and who was not, and it turned out to be no better than you or I guessing. And this is somewhat based on the curve type and progression risk. Next slide, please. So this is the whole central issue. The slide on the left are two patients, and most of them show up with a mild curve that the pediatrician has detected. 75 or 80% are going to be as the X-ray on the top with no progression. A very small percentage is going to be the X-ray on the bottom with progression to bracing and progression to surgery. So this causes a lot of problems there because we can't predict, we need to follow patients. And this gives direct and indirect costs, direct being doctor and X-ray costs, the indirect being loss of time at work, travel costs, etc. Serial X-rays are necessary, and we're thankful to have the EOS machine, very low dose for the past 10 years. It does cause a lot of worry among parents and a lot of angst. Sometimes there's unnecessary bracing, and sometimes we miss the opportunity to do a less invasive operation. So we don't have the answers, and mostly can just follow. Next slide. Common misconceptions, and I'll run through these quickly. Poor posture or slouching does not cause scoliosis or influence it adversely. Everyone with scoliosis will not be severely deformed. Backpacks don't cause scoliosis. They don't cause it to get worse, but can contribute to some back pain. And finally, diet and nutrition are important, but vitamin D is particularly important, as well as calcium and selenium. Next slide. A few more misconceptions. Swimming doesn't cause scoliosis, nor does it help it. A lot of grandparents in South Florida recommend swimming for everything, and it really is not a therapeutic thing. It's great exercise. Sports are recommended for everybody. Muscle imbalance and development treated by manipulation or exercise. Good evidence is lacking for the effectiveness of these modalities. Next slide. And finally, if you go online, this is what's out there. It's alternative scoliosis, which may be multiple exercise programs. And there's a myriad of supposed true therapies. And none of these have any scientific basis, and they're very expensive and usually not insurance covered. Next slide. So a couple more points. Scoliosis does not make you more liable to injury. It does not ruin your sports, hobbies, choice of occupation, or ability to have a family. And you can travel after scoliosis surgery. We have many people in South Florida coming from South America, and they go home on the plane at 1 week post-op. So travel is permitted early. Next slide. So I'll stop at that and pass it back.
So thank you, Dr. Shufflebarger. As always, a pro staying right on time. We have a question from Olivia. asking about a saliva test and whether that shows any promise. I think probably referring to the old test, no longer in use, Score.
That was the Scoliosis score test, and we had great hope for it, but it failed miserably.
Along those lines, do you see any role for genetics in either treatment or prognosis in the future? Do you know of any areas of development and where this may show promise?
Baron, I don't think we know enough to be able to comment on that. I think there's a lot of ongoing research at several centers in the United States, but we just don't know enough to answer that.
Great. Well, it looks like we have another question, this one from Vanessa. Why do many surgeons follow the wait and see approach for smaller curves instead of seeking Schroth physical therapy or other types of scoliosis specific exercise therapy? Should we be more proactive even for patients before they get into the curves that require bracing or surgery?
I'll take that too, if it's okay, Baron.
Yes.
I counsel many parents that we don't know what's going to happen to your curve. If we keep a close eye on it, nothing bad is going to happen, and we can get the appropriate treatment when indicated. Schroth therapy is another avenue. I don't have any objection to it, and we'll prescribe it if the parents wish that. There's no evidence that Schroth therapy has any lasting positive effect on preventing curve progression.
Well, thank you, Harry. I would say also in my practice, we use it to help patients with postural difficulties, and I think it can be very helpful there especially. Okay, we're going to go on to the next talk. I'm sure many of you are interested in hearing about the role of non-fusion and specifically vertebral body tethering, and Dr. Mianji will talk to us about that. Thank you, Feroz.
Thanks, Baron, and thanks, everybody. Good evening. As Baron said, I'm Feroz Mianji, and I practice in Vancouver in the beautiful province of British Columbia. And I was charged with talking about, taking a balanced approach to both treatment options that we're seeing more and more in the area of scoliosis. Harvey, can I get access, please? So I think many of you know this, that when we look at scoliosis surgery, we do have certain goals, and the primary goal really is to prevent the progression of the curvature. We want to do this with a single surgical event, and as Dr. Lahner said, we're trying to straighten the spine or trying to restore the natural curves that the spine should have, so we want to have a good cosmetic result. Fusion, of course, remains the gold standard, and many of you know this, where the spine is instrumented with screws or hooks, and two rods are going to be placed, manipulating that spinal column and fusing it in a straighter position. And really with fusion, the indications are quite clear-cut. Generally, if you have a curve over 50 degrees, and even if you have stopped growing it, your surgeon may discuss the option of fusion surgery with you. And when we look at fusions over time, we know that the cosmetic result is very predictable. You get this immediately, and it's got a track record. It's been done for a very, very long time. There's been some changes in a little nuances in terms of what we use for rod material or how we anchor the spine, but the overall goal of putting the spine in a straighter positioning, holding it there, remains still the gold standard for scoliosis surgery. Fusion, however, is fairly invasive. We instrument the spine. We also have to start, we need to cut some of the vertebrae so that we can put the spine in a straighter position and hold it there. And in order to do that, we put down a fair amount of extensive bone graft, so that area of the spine will be a solid a piece of bone, and it actually will fuse in one column of bone. So it is a fairly invasive procedure. But the correction, again, is immediate. You can get a fairly substantial correction of the deformity to hold you in that position. And again, when you're doing a fusion procedure, you'll see that immediate correction. Now, what about the chance of requiring further surgery? After fusion, it's fairly low, anywhere from 4 to 6 to 13%. Even 13% is a high number in a single series. But many surgeons would consider a fusion procedure to be one and done with predictable results. So the chance of you requiring more surgery after fusion is fairly low. The other common concern is, what about return to activity? Well, generally, you can return to anything high level at about 6 months. Some centers may push that to a year, but I think the point here is that you can return back to your activity. This is a patient of mine who, after surgery, landed a job modeling, and this was for the first ever Google Pixel phone. She sends me beautiful emails from time to time and says to me that, even though before my operation, I felt constantly discouraged that I wouldn't be able to get back to being physically active, she actually felt after fusion that she was much stronger. And lo and behold, she's a firefighter in the interior of BC now. So I think she's done, she's done very well following a fusion procedure. Now, having said that, though, we are aware that when we do our deformity correction in fusion, there has to be some motion loss. Whether you don't feel it functionally at the time, there might be some implications later on. And motion to many of our patients and all of you is very, very important. And I think it's a goal that surgeons also have been tackling for many, many years. Michelle Marks, who runs the Studying Scoliosis Straight Foundation, is also a very well-known researcher and has done a lot of work around this, highlighting that although fusion is the gold standard, it certainly may have implications, in particular when you're fusing down into the lumbar spine. And so we take all this, very seriously, I think. And about 20 years ago, the X-rays on your left here are actually of an animal model. And that's when some basic science research was coming around looking at non-fusion possibilities where the spine was anchored with a tether. And in fact, a deformity occurred. So it actually occurred in a straight spine. And then by putting a tether or a non-fusion sort of option on a curved spine, it corrected. And then the study on the right here was the first ever published case report of a tethering procedure done in a patient in 2010. Now, since then, there's been a lot of studies showing that VBT or non-fusion technologies can be done in scoliosis, but there are a lot of unknowns, and I just wanted to highlight that through the talk as well. First and foremost, VBT, when asked about its invasiveness, it is generally considered less invasive than a fusion. We're able to do thoracic curves through a camera, through small incisions, so it is considered a little less invasive than a general fusion procedure. However, the correction is gradual. So you won't see an immediate correction following a VBT procedure, or you generally shouldn't. And over time, you may see some correction of your spinal deformity. What about return to full activities? Well, it is shortened, and you heard earlier as well by a nice presentation from Alexis that at 6 weeks she was up doing what she wanted to do after VBT, and that's pretty consistent. At most, some conservative centers might make you wait about 3 months, and this is one of our patients after VBT went back to her winning streak of cross country at minimum 8 months. So she's done very well following the VBT as well. Now, I think it's really also important to recognize the chance of requiring further surgery after a non-fusion or VBT is fairly high. The studies that are coming out now will say anywhere from 26 to 47%. So this is much more, a lot more significant than our fusion procedure. So I think we really need to be aware of that and recognize this as well. And why is that? Well, some things in VBT that have been highlighted that we don't see in fusion, and one is this concept of overcorrection. Sometimes the technology is too effective and you have too much growth, and you can get a curve swinging the other way. The other concern we've had is tether failure, where the tether won't hold, and unfortunately it can break and your deformity can recur. And this is really implied by X-rays, that over time, if the X-ray, the heads of the screws are splitting apart, then we're concerned that the tether has failed. So the challenge right now is really, who's the ideal patient for the technology? Timing is a big issue. How big or small of a curve can we treat? And how young or old does the patient have to be? And so to answer these questions, of course, we know that we need data. We need to do data with lots of patients so that we can show this bench to bedside sort of translational work. And that's what you need in clinical trials. And it's the only way that you can offer medical advancements to everyone. And the Harm Study Group in Studying Scoliosis Straight has done a great job looking at patient registries and other areas of scoliosis, so we can collect patient data. This is aggregated from multiple sources all around the world, so we can answer all these difficult questions. And of course, you know, in the 21st century, we all understand the power of data. You know, it's you know what we say and what we do, how we buy, what we purchase, all that really is driven by data. And I think we all would respect you know, these conglomerates of data acquisition and data presentation. So I think it's really important that we understand how important collecting data is. Really, when you're looking at new technologies to be introduced. Having said that, you know, again, the Setting Scoliosis Straight Foundation and Harm Study Group has really led the way and have already set up some patient registries to look at this, both in a retrospective manner, so patients that have already had this technology done over the last 10 years versus those that are going to have it, say, going in the future. And this is really important for us to get you know, get a complete idea of what's happening between fusion versus non-fusion, so we can do a direct comparison of these patient groups. And so, you know, I would say when you're looking at decision-making around the non-fusion, you want to really expect more discussions around the timing of surgery, your curve size, your skeletal maturity. So really whether or not you're a candidate. And you may need to have an appetite for potentially more surgery. For a fusion, the discussion is rather concrete. The parameters in terms of your curve magnitude are set. You can expect a predictable cosmetic result, and there will be a low risk of a reoperation. And so, you know, if you are looking for a really good cosmetic result, a single surgical event, then a fusion is probably where your mindset should be. But if motion preservation is important and an earlier return to activity, then I think non-fusion is the way to consider and discuss those options with your surgeon. You know, I think VBT has probably got some element of where it needs to stay in the last sort of 10 years of my practice. It's settled in the last 3 or 4 years about 30%. So I don't only do fusions or only tethers. I think it's important to respect that both options can be around, but we still need a little bit more data in VBT and its place in this. And I'll just end very quickly with a very short video here of a patient. There's two here, so you'll have one that has had a procedure done and one that hasn't. I don't know if the volume is playing though, I apologize. So you can appreciate that even after surgery, many patients really the amount of spinal motion that they require can be fairly significant. And so both of these are doing some incredible things with their back. But again, to let you know that even after surgery for scoliosis, life can return. So, and I think I'll end it there because it's a fairly lengthy video. Thank you very much.
Well, thanks, Feroz. An excellent talk that really highlights a lot of the controversies and interest in vertebral body tethering. We have some questions we're going to run through. The first one is from Karen. She's asking that there seems to be a threshold for surgery over 50 degrees, but some 40 to 50 is frequently portrayed as a gray zone. What's meant by a gray zone as an indication for surgery?
Yeah, that's a very, very, very good question. You know, a gray zone is, I think, where you and the treating surgeon can consider it. I think the gray zone really means that we don't have concrete data, at least from our natural history studies, that curves between 40 to 50 would progress, because all the treatment options for scoliosis, be it bracing, be it Schroth, be it surgery, is really prevent the progression. And so when we're looking at somebody that's skeletally mature, our numbers would say if your curve is over 50. Now, does that mean that if you're less than 50, you will not progress? It doesn't mean that either. There are some patient populations that between that 40 to 50 may progress. So I think the gray zone is that it's not clear cut. It's not an absolute indication to have an operation, but it can be considered if you look at other factors. Sometimes with scoliosis and where they are in your spinal column, you may have a bit more of a trunk shift. There might be issues of pain as you get more mature. And again, you know, to that end, that patient population is also being studied through the Setting Scoliosis Straight Foundation, because historically we don't have good data, and hopefully over years we can actually make that gray zone a little bit more black and white.
Another question sort of along the same line from Warna Lim. If you have a patient who's 16 or 17 years old, has a curve that's in their 54 degrees, low 50s, and you do Schroth and you do some bracing and you get the curve down into the 40s, does that mean that now you don't need surgery?
Yeah, another very, very good question. I would say even if you get it down to the 40s, that's excellent. And I would say at that point in time, my bias would be that no, you don't need surgery. And I think surgery is an option. I think if if it's presented that it's a must, that really should be cautiously entertained. So I think if you do get it down to 40, and if you're skeletally mature and you maintain a good muscle balance around your spine and your core, I don't see the need for surgery.
Thanks. There's a question about yoga and exercise. And actually, I want to go back to Sofia. Sofia, if you wouldn't mind unmuting. Because I was impressed by the fact you're a rower and also you're a walker for exercise. Is there any specific type of exercise you use, like yoga or Pilates, or any special exercises that help you do your physical activities?
I love doing Pilates to help strengthen my core. I was doing physical therapy for about a year before the pandemic started, and I was doing a lot of core strengthening and also quad strengthening exercises to try and even out my hips. And those really helped.
Is there anything you use for your rowing?
Not in particular, no.
You find that your back gets a little bit more sore, or more sore than your fellow rowers, or that doesn't bother you more than anyone else?
Yeah, that definitely does happen. During competition season, I'm actually a coxie because I feel like my back would be a bit too painful to row during competition season. But when I'm training, I definitely train with my teammates, and my back does tend to hurt quite a bit.
Thanks, appreciate it. So for Dr. Mianji, so when a patient comes in and asks you if they have let's say a 45 to 50 degree curve, and they're asking about tethering versus surgery, what are the criteria that you might explain to them would point in one direction or another? Do you have any hard?
Sure. Another very good question, Dave. I think one of them, if you have a 45 to 50 degree curve and you're looking at that option of surgery, first and foremost is, in my opinion, you need to know your skeletal maturity. So if you have a patient that's quite mature and they've got a curve in that range, then I don't think the VBT would be effective. I still feel that you need growth, and you need to modulate the growth, and that's the emphasis. That's been the emphasis from the basic science models to have VBT introduced clinically. So I think that would be a big question right then and there. The other thing about VBT, if you're considering non-fusion versus fusion, is flexibility. So you really need to know how flexible that curve is. And generally, we do these x-rays where the patients would bend from one side to the other. So that lets us know how much that curve is going to potentially correct. And we'd like to see that. The number generally thrown around is a curve that would bend to less than 30 degrees to allow us to consider that. And then, Dave, the question would then be posed, what's important for the patient and the families? Is it potentially that preservation of motion? Is it a good cosmetic immediate result? If it's the latter, then fusion is what we would discuss. But if it's motion preservation, if it's the understanding that every X-ray that you'll see at 6 months, you might see a little bit different in terms of the curve as it's getting better, and you have enough growth, then VBT would be the option.
Thanks. Well, if you look up on the screen there, one of the participants is asking about apifix, which I think is a surgical technique. Could you comment a little bit about that?
Sure. Apifix has been FDA approved. It is a screw rod construct, so there may be a little bit of stiffness there, but it involves capturing the spine only on one side, so on the inside of the curve. It has some very strict criteria for indications. Generally, the curves are between about 40 to 60 or 40 to 65 degrees. I think it's actually 40 to 60. And again, the flexibility needs to be less than 30 degrees for flexibility. There's also some special measurements that you have to do from the side. Dr. Lahner showed some natural curves of your spine from the side, so it can't be too kyphotic. So you can't consider the apifix in those considerations. So it is something that is being offered. I haven't introduced it into my practice as of yet, but I think there are some strict criteria. But just based on what the information is here, the 40-degree curves, a lumbar curve of 30. If you do have two curves, the AP fix is not indicated. It has to be simply a single curve that you want to treat, either the thoracic or the lumbar curve. So I think in this case, you might need a little bit more information before we can consider AP fix for this patient scenario that's on the screen.
Dave, I would just add to that. Actually, there's been an extension of the labeling through the FDA for ApiFix, and that's actually indicated now for curvatures of 35 to 60 degrees, and also in the skeletally mature patients, so RISR 5. So it is an option for patients who have reached the end of growth, who meet the criteria that Dr. Miyagi pointed out.
Regarding,
Thank you, Baron.
can I make a comment, David?
Sure, please, Harry.
I think the ApiFix is a reasonable option for thoracic curves. I think ApiFix for lumbar curves is a terrible option. It acts exactly like a Harrington rod. They're all flat over the segments of instrumentation. So I would consider it for thoracic, but not for lumbar curves.
So upper curves, not lower curves.
Yes.
Thanks. Interesting perspective. Harry has seen it all. Okay, thank you very much, Feroz, Harry, and Baron. And we're going to move on to some questions that I'm sure a lot of parents especially have about their kids when they grow up. Does having scoliosis and having the treatment for scoliosis affect their ability to have a family? And Dr. Cahill is going to help us with that.
Great, thanks, Dave. So I know there's still some unanswered questions, and I think we're going to have some time after my talk to get to those, but also hopefully I can answer one or two of them during my talk. And so I've been tasked with, if you're going to have a scoliosis surgery, and particularly a fusion, what is your life going to be like after that? And the short answer is not very different. I know Dr. Miyagi talked about this a lot. One of the big issues between the two options that we have for scoliosis fusion, the two main options, are a fusion and a vertebral tether. And it seems like the rates and risk of having a second surgery is much lower within AIS fusion. I can't really give you a lot of information about what life is going to be like long-term with vertebral tether because it's so new and we don't have that data. It's really been around for less than a decade at this point. So we don't know what the rest of adulthood is like with that surgery. But we do have really good information about fusion surgery because it has been around for a long time and we've had a long time to sort of perfect it and get better at it step by step. And the data shows that at worst, maybe 13% of patients that have a posterior fusion for scoliosis have a risk of having another surgery at some point in their life. And the reality is that if they're going to need another surgery, the earlier and sooner they are after surgery, the more likely that need is going to arise. And the longer you are out from surgery, conversely, the less likely you are to need a revision surgery. So it's not a perfect surgery. We talked about the loss of flexibility and motion. And maybe a small percentage of patients have a slightly increased amount of back pain, but it's generally not disabling or limiting in terms of career options and sports choices and things like that. It really should not get in the way of how you choose to live your life. And the way I talk about that with families that come to see me, a lot of the parents have the notion in their mind what they've seen in their friends and classmates that had a scoliosis fusion during their generation 30 years ago or so. And in that case, it was really a life-altering surgery where those patients didn't quite have the same active lifestyle and ability to participate in sports, more likely probably to have sedentary jobs as adults. Whereas now the technology has evolved so much and our techniques and abilities to take care of patients with scoliosis have really gotten to the point that it's really more of a bump of the road than it is a life-changing procedure. So yes, it may mess up your summer vacation and get in the way of doing some of those things, but it's not something that should affect the rest of your teenage years and your adulthood going forward, for the most part. And then the other big questions that a lot of our patients and families have that have undergone a spinal fusion is what is life going to be like for those girls that go on to become pregnant and have children. Does having a scoliosis fusion preclude those things? Does it make them more painful or more risky? Again, the short answer should be it should not, but it seems like it has. A lot of the best data that's relatively old at this point comes from Scandinavia, where they have nationalized healthcare systems and are able to track all their patients and find out how they're doing. They found some interesting things, that those women that had a scoliosis fusion as adolescents did not have more back pain or be more likely to have a cesarean section, although they did find that they had a higher rate of vacuum extraction. But the setting scoliosis group has probably the largest registry of patients and women in particular that have had a scoliosis fusion, and we're actively following our patients to try to find out how well they're doing and what childbirth and pregnancy has been like for them. Some of the important things to keep in mind is that one of the key aspects of anesthesia during childbirth is either getting a spinal or an epidural injection, and those things may be close to where your implants and your rods are. So one of the things we found is that the majority of our patients did not get to meet with the anesthesiologist until they were in labor, which we think is probably too late, because we think that all women should be able to get whatever anesthetic they want during their pregnancy, even if you've had a scoliosis fusion. But that's going to take some planning and some sort of active advocacy on your own part for your own plans for pregnancy and childbirth. So one of the most disappointing things that we found is that 39% of our patients did not have any analgesia during their pregnancy, which, if we look at national averages, that's more like 9 or 10%. So that's a huge failure, and that's really probably just a failure of information. We encourage our patients to really talk to their anesthesiologists and their obstetricians early in the pregnancy and make a plan that they can get the epidural or spinal that they want when the time comes. And then the great news is that every single baby that was born to the women that have had scoliosis in our registry were healthy, and the one patient that was not healthy, it was because of a genetic issue that had nothing to do with their scoliosis. And so some of the recommendations we have is to keep a copy of your x-rays and show those to your obstetrician so they can start to plan where they're going to place spinals and epidurals. Understand and know what the levels of your spinal fusion are so you can have that conversation with an obstetrical anesthesiologist, and then really have conversations early in your pregnancy with your obstetrician. And we've given you a list of these questions that might be useful. And if you're still not getting the answers and support that you think you need in terms of analgesia and plan for your pregnancy, talk to your AIS surgeon. Even though you may not have talked to them for 10 years or more, we love getting calls from old patients. We also love baby pictures. So please use your AIS surgeon as a resource when it comes time for pregnancy and childbirth. And now we'll open it back up to the question and answer section.
Excellent, Pat. Thanks so much. And I would just echo what you just said. We really love to hear from our patients. And, I've been in practice long enough that I've seen some patients 20 and 25 years after their initial surgery. So we learn a lot from following our patients over time, and it helps us be better doctors and better able to answer our current patients' questions and their families. Pat, there are no questions on pregnancy and long-term outcomes so much. Here's one, though, about congenital scoliosis in a family who has an 8-year-old with a T4 hemivertebra, so a half a vertebra, and it's been progressive. It's gone from 18 degrees now to 27 degrees in an 8-year-old. Is there a role for surgery? How would you treat that patient in general?
Yes, that's a tough question, Baron. So that's a form of scoliosis called congenital scoliosis, where the shape of the bones are different than most other people's, and it's very much individualized, the treatment decisions and plans for those patients. And there's a number of factors that go into those decisions. We have to look at the overall magnitude of the deformity. So we talked about the curve getting worse in that patient. But we have to look at the overall balance. Is the head lined up over the pelvis, if you look at the patient from the side and from the front? And then we really also have to look at the rate of progression and how much growth they have left. And so there's a lot of different treatment options. And the key there is being engaged and following regularly with the scoliosis surgeon for a complex problem like that. But there's a number of treatment options that may come into play, such as just removing that one vertebrae and doing a short fusion around it, to doing a longer fusion once the patient's a little bit older and closer to full grown. And then other options in between include temporary kind of implants like growing constructs and growing rods and vectors and magnetic rods and things like that. So I can't give you a specific answer on that particular patient, but I would say that it's a tough problem, and having a good doctor to partner with is going to be an important part of that.
I would agree. I think it's difficult for us to give very specific guidance on in a webinar like this, but certainly getting an opinion and second opinions are always welcome from colleagues who are experienced in the treatment of these conditions. Dave, do we have time for one more question?
Yes, please.
So here's a question, Pat, on a patient with progressive scoliosis, and there's a strong family history of degenerative disc disease. Is there a benefit of a non-fusion approach in this case versus fusion, assuming the patient meets the criteria for a non-fusion? What are your thoughts on that? Do we have data yet on that?
We don't. We don't even really have data on the interplay of those patients that are afflicted with scoliosis and at risk for degenerative disc disease, both of which are largely genetic driven conditions. For me, it would seem to theoretically make sense that somebody who's at risk for degenerative disc disease might be a stronger candidate for a motion preservation kind of surgery. The thing that I'm most excited about vertebral tethering is not so much the earlier return to sports or the flexibility that's maintained for participation in sports and in activities, but the benefits that flexibility may have on preventing degenerative problems below where they have the scoliosis surgery. And so for somebody who's already at risk for degenerative disc disease because of their family history and things like that, that might be somebody who I would ask to consider more strongly a motion preservation solution like vertebral tethering. I don't know. What do you think, Baron?
I think you're right, and I think time will tell as to whether or not the non-fusion approaches will have a better long-term outcome in terms of degenerative disease changes in the spine below.
Right.
But I think there's a lot of promise, and I agree that's an area of interest and further study. Maybe a last question for Dr. Schuffelbarger. This comes about the likelihood of scoliosis developing in a sibling who has scoliosis. So what is the likelihood of a sibling developing a curve? Or perhaps
some numbers
also a parent who has scoliosis. What is the likelihood of a child then developing scoliosis?
I remember a couple of numbers. First, a woman who has scoliosis, 10% of her female children will have scoliosis. A woman with a child who has scoliosis, I think the percentage of the sibling is also about 10 to 15%. If you have better information, speak up.
The only thing I'll add to that, Dr. Schuffelbarger, and I had a slide on this that I had to remove because of time, is that after you do have if you're somebody who's had a scoliosis fusion, or a woman that's had scoliosis fusion and then has a child, one of the most important things you can do is make sure that your child's pediatrician is checking closely for scoliosis and routinely, because of that 10% risk of scoliosis in the next generation.
And probably if you're a woman who has scoliosis surgery, you're going to be checking your own kid.
And in fact, there's an app for that. Yes, there's great scoliosis screening tools that you can use to look for asymmetries in your children's back. I use one called ScoliScreen, 99 cents. It's a glorified level that you can use. It's the same tool the school nurses use for screening for scoliosis.
I think that's a fitting end to this session. Dave?
Yeah, can we, so we'd like to thank everybody for attending and for participating and sending your questions. We apologize if we didn't get to your question. If you enjoyed this event and grateful for the information, you can consider a donation to Setting Scoliosis Straight by going to our website. or text scoliosis, and your contribution will help with future patient education. We thank you so much. We also want to thank these industry sponsors who help make this possible. DePuy-Synthes, Stryker, and the other groups, EOS, NuVasive, Medtronic, all helping Study Scoliosis Straight to provide this education. Next slide. And upcoming events. We're very excited. On September 11th, we're going to have an international Power Over Scoliosis webinar with participation from faculty and families from around the world. So mark your calendar for that one. And with that, I think we'd like to finally ask if you wouldn't mind answering a few key survey questions for us. Helps us make these education webinars better and more responsive to what you want. So thank you for participating. Thank you for your questions. Thank you for your patience with us. And thank you to all of the faculty and to our to Alexis and to Sofia, who did such a great job. Good night, everybody.
Bye.
Nice job.
Hi.
Dave.
Night.